Depression is the leading cause of disability worldwide. More than 300 million people are affected by depression, and currently, 1 in 5 people are affected by any mental health condition. So, whether that's you, your friend, some of the patients you work with, it impacts a tremendous amount of people.
Three, two, one, liftoff.
Welcome to the Ketamine Startup Podcast. I'm Kimberly Chan Ko, and along with my co host and partner, Sam Ko, we're two physicians who run a ketamine infusion clinic in Palm Springs, California. Beyond our own clinic, we've had the privilege of helping doctors and other licensed medical professionals across the U.S. open their own ketamine therapy clinics. On this podcast, we share the realities of starting and running a ketamine infusion clinic, marketing it, and more. This episode is part of a presentation Sam gave to the UCLA and Betty Ford Addiction Medicine Fellowship. And if you're looking for a good overview for the current state of mental health, how ketamine therapy fits in, along with the relevant scientific articles, plus a bird's eye view of providing this therapy, this episode is for you. Let's dive into the episode.
So, today we are going to be discussing all about ketamine infusions, a novel approach for depression, PTSD, anxiety, and chronic pain. It's really an honor to kind of educate and share with you this information today. A couple of disclosures. We are going to be discussing the use of IV ketamine therapy for off label use, meaning it is not FDA approved for these indications. I'm also the founder and medical director of Reset Ketamine in Palm Springs, as well as the co-creator of ketaminestartup.com, where I teach basically ketamine therapy to other physicians. Let's go over what we're going to be covering today. Part one, we'll be discussing the current state of mental health and the history of ketamine. Part two, we'll be getting into ketamine's mechanisms of actions and the scientific studies. We'll also be going into part three, which will be going into ideal patient selection, dosing, scheduling, adverse effects, things to watch out for. Part one, let's jump right in. So, the current state of mental health and the history of ketamine. So, we have a huge problem currently with rising rates of depression, post traumatic stress disorder. It's also known as post traumatic stress injury, anxiety, suicide. And depression is the leading cause of disability worldwide. More than 300 million people are affected by depression. And currently, 1 in 5 people are affected by any mental health condition. So, whether that's you, your friend, some of the patients you work with, it impacts a tremendous amount of people. And traditional medications for some of these mood disorders, as you probably know already, can take weeks, months to kick in before it gets into the stable levels. Now, in addition to the mood disorders, 17 million people plus in the United States are affected by severe chronic pain that is debilitating. Now, why this is important is when someone is in an extreme physical pain or emotional pain, one of the things that can occur is suicide. And so there is a rising rate and incidence and prevalence of suicide. It's actually increased 33% since 1999 to 2017. It is the second leading cause of death for Americans between the ages of 10 and 34 years old. And worldwide, internationally, close to 800,000 people die from suicide every year in the world. And interestingly, there are twice as many suicides in the United States as there are homicides. So this is a problem that is prevalent and rising. Accordingly, we need more options available to us in our arsenal of healthcare. And this is where I'm going to jump into ketamine as an option. So let's go over the brief history of ketamine today. Ketamine is a member of the aerocyclohexylamine group. And so if you remember from taking organic chemistry, yeah, brings back fond memories for some of us and maybe not so fond, but it is a member of this general class of medications and structures. Now, ketamine is actually a derivative of another drug, also in the aerocyclohexylamine group. It's called phencyclidine. Phencyclidine was first made in 1926, so almost 100 years ago. And then in 1956, there was a pharmaceutical company, Park Davis out of Michigan, who patented this medication for use as a general anesthetic. However, they actually found that it created these prolonged psychotic symptoms even after the phencyclidine was administered. So in 1965, they said, hey, we need to stop using this. Too many side effects, not a great drug. So they discontinued it. But there were some creative chemists who turned it into a drug of abuse, actually, and they made it in their homemade labs. And you may have heard it referred to as angel dust and PCP. So it was a real big issue in the 70s. Now, Park Davis Pharmaceutical knew they had a, pretty effective medication with the side effects, so they tasked Dr. Calvin Stevens in 1962. He was a chemist at Wayne State University. They said, "Hey, we have this drug. Is there any way you can make it safer than the phencyclidine?" So he took phencyclidine, created a many derivatives. One of those derivatives was called CI 581. CI stands for Clinical Investigation Drug 581. Out of all of the derivatives that he made, he found this one in particular to be most effective. And I'll tell you more about what made it that way. Once he had isolated this derivative, it was later renamed ketamine. And one fun fact why it's called ketamine, well, if you look at this chemical structure here, there's a ketone group right here, if you remember again from organic chemistry, and an amine group right here. So if you take the ketone group and the amine group, ketone and amine, ketamine is the reason why we call it that. So once it was invented and they had tested it on rodents and other non-human mammals, they began testing it in human subjects. So this is where Dr. Edward Domino in 1964, he took, quote, volunteers from Jackson Prison in Michigan, and they took 20 volunteers who received intravenous ketamine. And what they found was that they were describing these like hallucinations, dreamlike, non-ordinary states of consciousness. They described it as like, I feel spaced out, floating. But what was most effective was that at the highest doses, it did induce a profound anesthesia. And they coined it a dissociative anesthetic because it seemed to dissociate the mind and the body, which in turn allowed the doctors to perform procedures for those patients. So once they ran it through the human trials, it did become FDA approved in 1970. So the FDA said, yes, we approve this medication for use as a anesthetic for children, adults, and elderly during surgical and diagnostic procedures. So this is FDA approved on label for this indication. And ketamine, once it became approved, it actually became the most widely used battlefield anesthetic, sedative, and analgesic agent during the Vietnam War. So, what was very useful for the combat medics out there was they could give someone a shot of ketamine intramuscular, and it would allow them to save their respiratory status so that they could still breathe normally on their own and then be evacuated to a military hospital. So from 1970 to 1990, it was extensively used in the operating room, mainly by anesthesiologists and surgeons. Later in 1990, a landmark study was published in the Annals of Emergency Medicine. And they were looking at pediatric patients, and they found, hey, not only can it be used safely in the operating room, but it can even be used safely in the emergency department for use as a medication for procedural sedation. And this research was actually done at Loma Linda University, which is, right here in Southern California. It's where I did my residency training. And since that period, once this paper came out, then again, it expanded from the operating room and then into the emergency department. As of today, ketamine has been used in humans for over 50 years now. From 1970 to today, 2024, it is on the World Health Organization list of essential medicines. So these are medications that any healthcare system needs to have available for use. Next, I want to jump into part two. So, how exactly is ketamine working, the mechanism of action, as well as some of the scientific studies that are available? So, we know that ketamine works on a neurotransmitter. It's called glutamate. Glutamate takes effect on the N-methyl D-aspartate NMDA receptor, and ketamine seems to prevent the NMDA receptor from being activated by glutamate. And glutamate is one of the most common neurotransmitters in between the synaptic connections. It's actually more common than serotonin, norepinephrine, dopamine. It is probably counts for like 90% of that neurotransmitter activity. And we believe and hypothesize at this point that by blocking activity of the NMDA receptor, that this is what is creating these analgesic and anesthetic effects. Now, ketamine is interesting because it doesn't only impact the NMDA receptor, but it does have some direct and indirect effects on other receptors. So, for example, it affects the mu kappa delta opioid receptors, the dopamine D2 receptors, the serotonin receptors, acetylcholine, GABA, cannabinoid, nitric oxide, sigma. So, ketamine, it's not like one of those medications that just work specifically on one, but a broad spectrum. Like if you think about a beta blocker, it can be very specific to beta 1 agonist or beta 2 agonist. This one actually has a host of mechanisms and effects on multiple cellular receptors, which is very interesting because ketamine seems to help reverse this glutamate, which is an excitatory neurotransmitter, from being activated. So, some studies are showing that chronic stress actually causes increased glutamate levels and then later excitotoxicity to the surrounding cells, which further leads to the dendrites being retracted, the dendrites in the brain's dearborization happening going on, as well as decreased spine density. And ketamine, we believe, has the potential to reverse this due to increasing BDNF, brain derived neurotrophic factor, increasing protein synthesis, synaptic strength, synaptogenesis. And bottom line, all of that simply leads to neuroplasticity for the brain. But there's a quote: studying neurons to understand consciousness is like studying letters to understand Shakespeare. So let's jump into what the patient may experience when they're receiving ketamine. And as I mentioned in the studies, they found that it could create these hallucinations. So maybe it's not a side effect that's potentially a bad one, but beneficial. Dr. Eli Kolb, he published a paper in 2014 titled Ketamine Psychedelic Psychotherapy Focusing on the Pharmacology, Phenomenology, and Clinical Applications, where he described various non ordinary states of consciousness, NOSC, from the patient perspective. So specifically, there's four levels. The first level being the empathogenic experience, which is kind of a very gentle awareness of the body. They feel comfortable, relaxed, their ego defenses are reduced. They may feel empathy, compassion, warmth, love, peace, euphoria, kind of these dreamy, non-specific, colorful visual patterns, kind of like one of those old computer screensavers that people may have seen back in the days. One level above that is an out of body experience that he described, where patients may have a separation from their body, significantly diminished ego defenses, even like visits to mythological realms of consciousness, encounters with aliens. They may even see like deceased relatives, spirits. They may have vivid dreams of the past, the future, or they may even experience their own birth process. A third level above that would be like a near death experience where patients reported kind of this feeling of departing from their body, ego dissolving, loss of identity. They may experience a physical or psychological death. They may experience being a single point of consciousness, simply aware of itself. Or they may just relive their own life, kind of thinking about how their actions have impacted others and kind of judging themselves. Now, finally, and this is more at the highest doses, the patients reported this ego dissolving transcendental experience. So, described as ecstatic state of dissolution of boundaries between the self and the external reality, complete dissolution of the body and self, soul. They may even report transcending normal space time, mass continuum. They may experience a feeling of collective consciousness or unity with nature, universe, God, sacredness, kind of like a mystical spiritual experience almost. And we believe that some of those experiences may be contributing to the patient's healing as a possibility.
Hey, listeners, this is Kim, and I just want to acknowledge that you're here for a reason. Maybe you're stuck in a cycle of long shifts, feeling a little burnt out, and wondering if there's any other way to practice medicine, especially on your own terms. We've been there, and that's exactly why we created this free checklist, your step by step roadmap to starting a ketamine clinic without those costly mistakes. Grab your copy now at www.ketaminestartup.com/checklist. It's completely free because we want you to succeed, not struggle. And hey, if you're driving or mid workout, don't sweat it. Just check out the show notes for the link when you're ready. And again, that's www.ketaminestartup.com/checklist. Now let's get back to the episode.
So now let's jump back into the science behind this. So as I mentioned, between 1970 to 1990 operating room, and then after 1990 in the both the OR and the ER. And then what was really interesting because in 2000, Dr. Berman and his colleagues out of Yale, they published this paper. They took a very small sample size, so just 7 patients with depression, and it was placebo controlled with saline infusion. It was double blinded, and the study was published in the Society of Biological Psychiatry in 2000. And in this small study, if you see this graph here, you have these open circles, which represents the saline infusion, and then you have the black circles, which represent the ketamine arm. And if you look at the y-axis, the mean change in the Hamilton Depression Rating Scale, they found a robust, significantly different improvement and effect on the patient's depression symptoms. So this was really interesting, and they were like, "Hey, groundbreaking research," but again, it was a very small sample size. Since that point in 2000, multiple studies have come out with larger sample sizes, although they're, relatively small, which what we can do, if you remember from med school, grad school, residency, et cetera, that you can take smaller studies, pull them together, and create meta-analyses. And so this is an article published in the Journal of Affective Disorders in December 2020. They looked at the studies that were published between January 2009 to January 2019, and they looked at 28 studies and 35 publications, and they found that there was a strong beneficial ketamine effect peaking at 24 hours and even 7 days post single infusion that the patients reported benefits. And furthermore, when they did multiple infusions, it actually enhanced and prolonged the benefits of ketamine therapy. The most recent articles I'll get into is this one published in the New England Journal of Medicine, and this one was published in May 2023, Ketamine versus ECT for non-psychotic treatment-resistant major depression. So as we know, electroconvulsive therapy is the gold standard, and they were curious, hey, maybe, there's all this study happening with ketamine. Can it be an equivalent to ECT? And that's what this study showed. And it was a larger sample size. This one was 400 patients, 200 in each arm. And essentially, they found that the ketamine treatment was non-inferior to ECT, so just as beneficial without the side effects of ECT. Later, a second article, so this one was published just a few months ago in June 2024, and they did a secondary analysis of that initial study. And so this one is titled Ketamine versus Electroconvulsive Therapy for Treatment-Resistant Depression. The bottom line was these results suggest that outpatients and those with moderately severe or severe depression may consider ketamine over ECT for treatment resistant depression. So the science here for depression is quite robust. Now let's jump into anxiety disorders. This study was published in the Journal of Psychopharmacology in 2017, Dr. Paul Glue out of Australia, and they were curious to see not only is ketamine, could it be effective for anxiety, but, what's the appropriate dosages for it? And so in this one, they took, again, these are small studies, 12 patients were enrolled. They all had anxiety disorders, maybe GAD, seasonal affective disorder, panic disorder, who had tried antidepressants and psychotherapy in the past. And they were giving various doses, either 0.25 milligram per kilogram, zero point 0.5 mgs per kg, or 1 mg per kg. And this is interesting because overall, 10 out of those 12 patients, so 83%, reported either a 50% or greater reduction in their anxiety scores or their fear questionnaire scales after the higher doses, specifically the zero point 0.5 mg per kg or 1 mg per kg doses. And that these results lasted not only during the time of when they were getting the ketamine, but post, 3 to 7 days after each dose and, after multiple doses. And bottom line was that they found that the higher doses, there was a greater effect and duration of the improvements for the patients. Going to post traumatic stress disorder, also known as post traumatic stress injury. This one was an article published by Dr. Fetter in JAMA Psychiatry 2014. This was just a single infusion. It was a really early study just to see if it can be effective for PTSD. They took 41 patients, single infusion. It was randomized to either receive an active placebo, i.e., midazolam, versus ketamine at zero point 0.5 mg per kg. And what they found in the study in their PTSD scores, the squares represent the ketamine treatment and the triangles represent the midazolam. And there was a significant difference and improvement for the patients receiving the ketamine. Later, the same group of researchers, they were curious about repeated ketamine treatments. And so in this study, they gave them, I believe, sessions of ketamine. And again, if you look at this little graph here, the green squares represent the midazolam, and then the yellow oranges represent the ketamine. And again, there was a significant reduction in their CAPS 5 total score for those patients who received multiple doses of ketamine for their chronic PTSD symptoms. Let's jump over to chronic pain because this affects a lot of people as well. So, when I'm referring to chronic pain, the specific kind I'm talking about is neuropathic pain and or pain related to central sensitization. So some examples. Complex regional pain syndrome, CRPS, also known as reflex sympathetic dystrophy, RSD, a trigeminal neuralgia, fibromyalgia, postherpetic neuralgia, peripheral neuropathy. And what I've seen and the studies show it's less effective for like mechanical etiologies of chronic pain. So if someone has osteoarthritis or no cartilage in between their knees at their knee bone, like it's less effective for those and it's more effective for the neuropathic pain. And let's just jump over to the meta-analyses and systematic review for ketamine infusions for chronic pain. And this one was done by Dr. Orhuru, published in Anesthesia and Analgesia in 2019. So this meta-analysis revealed that there was benefits for up to 2 weeks after the use of, these single doses of IV ketamine. They also summarize that the evidence is robust for higher doses and longer durations of the ketamine treatments that were associated with a greater and longer pain relief. They hypothesize that what is happening is this like high concentration bombardment and blockade of the N-methyl D receptors, which are again related to the neuroplasticity. It can reset or reverse that central sensitization that can occur in neuropathic pain. So they recommended that IV ketamine be used on a case by case basis. It's not like a general blanket recommendation for everyone, that it be used for those patients who have tried multiple modalities and are not getting effective relief for their chronic pain with conventional treatments. Now, there have been more than 140 clinical trials studying ketamine as a treatment for these various mental health conditions. So you might be curious, well, who's the ideal patient? How do you select them? What's the dose? What's the scheduling? So I'm going to share with you about that. We had already mentioned the various indications. Now let's jump to the contraindications. So if someone has a family or personal history of schizophrenia slash psychosis, that may be a contraindication. If someone is in the active phase of their bipolar disorder, it could exacerbate that. If someone has uncontrolled hypertension, we know that ketamine does increase heart rate and blood pressure during the session. So if it's not controlled, it could, rise to dangerous levels. Also, active substance abuse. There are some clinics that are treating patients who are currently actively using, cocaine, opioid, alcohol. We don't do that at our clinic, but I do know that there is some research there. If someone has unstable heart disease, coronary artery disease, they may need to get a stress test prior to getting ketamine. There's also a theoretical risk of ketamine increasing the intraocular pressures slash intracranial pressure. So if someone has glaucoma that's not controlled, that could be a contraindication. If someone's pregnant, that could be a contraindication. We haven't done a lot of studies looking at the embryonic effects from ketamine. If someone has estrogen receptor sensitive breast cancer. That's also theoretical risk because ketamine and the metabolites of ketamine can stimulate estrogen receptors. If someone has had a prior adverse effect from ketamine, that could be a contraindication. Also, for suicide, if someone is actively suicidal, they have a plan, they're very high risk, it would not be someone we treat at the clinic because of the risk, and they would need to be potentially placed on a psychiatric hold. As far as dosing goes, the majority of the research was using zero point 0.5 milligrams per kilograms slowly infused over 40 minutes for 6 infusions. And so we take that research protocol and extrapolate it into generalized anxiety disorder, PTSD, bipolar disorder, social anxiety disorder. And in general, we start patients with the first session of zero point 0.5 mg per kg infused over 40 minutes. And the research shows that the dissociative effect, so some of those non-ordinary states of consciousness that I was mentioning, and the greater the dissociation, that it has a high prediction of improvement in their symptoms. So at our clinic, we believe in an escalating dosing protocol as long as the patients can tolerate it and their vital signs are stable, where we gradually titrate the amount of ketamine with each successive treatment. So we don't want to go too high. We don't want to go too low. So if you remember the Goldilocks story, not too hot soup, not too cold, but just the right amount. And everyone has their own unique optimal dose because some people are very, very sensitive and some people are not very sensitive. And so accordingly, here's the range of the ketamine doses. Again, it's weight based. And if you look at this graph here, you'll see, roughly the vast majority of people are in that zero point 0.5 mg per kg to 1 mg per kg range. And there are outliers. Some people need much less, some people need a little bit more. As far as scheduling patients, the initial studies, they were classically doing 3 times a week for 2 weeks for a total of 6 infusions. And then other studies have shown that just doing 2 times a week for 3 weeks can be just as effective. So those are some of the research protocols. And at our clinic, what I found is where we do the 6 infusions, but we space it out. So week one would be 2 infusions. Week two would be 2 infusions. Week three is a single infusion. And then week four is a single infusion as well for a total of 6 infusions. What I've noticed is that initially we want to group them close together, but the latter ones can be easily spaced out. And that's a little bit different from what's happening in the research setting versus what's happening in real life human application, clinical application of the research. Now, regarding pain disorder dosing and protocols, when we say the word pain, it encompasses so much. So it's not as clear. And the research shows there's a huge variation. Some of the studies would do very low doses, zero point 0.5 milligrams per kilogram per day. So very, very low dose, up to 1 milligram per kilogram per hour. And sometimes they'll do these in the studies in the meta-analysis I'd mentioned. They'll do like 30-minute infusions, 4-hour infusions for 10 days, 5-hour infusions for 7 days, sometimes for like 4 days in an ICU setting, monitored for, 4 days times by 24 hours. Very, very long sessions. But again, in general, what we found is the higher the dose and the longer the infusion, the more there is a reduction in pain for a greater period of time. So at our clinic, we'll either do like 80-minute infusions, 2-hour infusions, and 4-hour infusions. In particular, for complex regional pain syndrome slash RSD, I do typically 4 hours per day for 5 days, really to bombard all of those NMDA receptors. For the other pain conditions, such as fibromyalgia, trigeminal neuralgia, we could take, 1 day break in between the sessions. And again, extrapolating the data from the depression PTSD research, 3 times per week for 2 weeks can be an option. As far as the dosing for pain, again, it's a little bit higher. So people are typically anywhere, the vast majority fit between zero point 0.5 mg per kg per hour, all the way up to 1.25. That's where that vast majority of people are. Although, again, there's outliers where you can either do much less or a little bit higher. I do want to touch upon the acute and potential long-term side effects. So a lot of people, when they're first getting their ketamine at their appointment, they can be anxious. I tell patients it's kind of like, hey, if you're at a swimming pool and you see a diving board, which other people have dived off, but you haven't jumped off that diving board, it may feel a little bit scary, and that's totally normal. So they may have a little bit of anxiety. Sometimes it can even trigger panic attacks, where if they've not prepared for this, that they may have these scary, quote, bad trips. The other things we've seen are hypoxia. So we do continuous vital sign monitoring for our patients. Although ketamine is generally known to preserve respiratory function. I have noticed that some patients slow down and get really hypopnic during the infusions. There's also potential risks for seizures. Another patient had AFib with RVR, which was very surprising. And again, that can happen. And so having an emergency protocol in place is very useful. As far as the long-term side effects and post-infusion, a lot of people, maybe 10 to 20% will report some nausea. So we have IV Zofran, aka ondansetron, available, headaches. So we have IV Toradol. Some people may feel tired for like 24 hours. I'd mentioned that schizophrenia or psychosis history could be a contraindication. But if they're not aware, it can potentially trigger paranoia, psychosis, even full blown schizophrenia is theoretical. It can also cause interstitial cystitis with chronic long term high dose use and addiction, which I do want to touch upon because I'm sure you've heard in the news everything going on with Matthew Perry. So if you look at this graph here, and you'll see on the x axis the active dose over the lethal dose, meaning like essentially how dangerous is it? And then on the y axis, the dependence potential. So some examples like heroin, very high dependence potential and very dangerous, right? Risk of respiratory depression, overdose. Then you got morphine, you got cocaine, we got alcohol, moderate, we got nicotine, very high doses, got MDMA, moderate to low. And there are some studies happening with PTSD and MDMA. And you have caffeine, marijuana, LSD, psilocybin. And if you look at this one, you have ketamine. So ketamine is on this graph and the dependence potential is there, but it's low. So we want to be really responsible when we're using this medication. And as far as the active dose slash lethal dose, yeah, it can be dangerous. And we've seen this. We've heard obviously news reports about this. And I think it's important for clinicians to be cognizant that yes, the risk is there. It's low, but still there. And it can potentially be dangerous in the wrong hands. So we think that the risk of addiction is lowered by patients only accessing ketamine during their appointments with a doctor in person at the clinic. We also recommend not prescribing home ketamine, especially to those with a history of substance use disorder, and definitely not vials of ketamine for intramuscular administration by themselves. I think that is absolutely dangerous. Now, finally, I had mentioned addiction where ketamine can be a risk for creating that. But it's interesting because it can also be a possible treatment for substance use disorder, alcohol use disorder. So, for example, there was a paper published, Frontiers in Psychiatry, again, a systematic review looking at the efficacy of ketamine in the treatment of substance use disorders. And again, they found that there's some early research specifically for cocaine use disorder, alcohol use disorder, opioid use disorder, and it's kind of in the early stages. And I found this article from August 2024, so basically last month, where Exeter College in the UK, they're doing a study currently using ketamine to break alcohol addiction. So I'm really excited about this space. And again, I think it highlights like how someone is using the ketamine versus the molecule itself.
Thank you so much for listening to our podcast. We hope the information you gained from this episode will help you better understand the ketamine therapy landscape and serve you well. If you enjoyed this episode, we'd love it if you'd subscribe to our podcast on your favorite platform. And if you haven't already, plus feeling generous, we request a 5-star review on your platform of your choice. It would help us reach more thoughtful, entrepreneurial medical professionals like you. Thank you again for tuning in, and we'll see you in the next episode.